फिर देखते हैं कि क्या सिलसिला चलता है। अब मुझे रोक देना अगर ज़रूरत पड़े तो। क्या लिखूं हमद उस अल्लाह की लफ्ज़ों में जो ना मांगूं तो अता करता है, मांग लूं तो बेहिसाब देता है। And probably we all being have a faith in few things beyond our expectations, so I hope everything stays well. Okay, yeah, this was the slide which I was supposed to do last time. There are three brain areas, important areas of the brain. The question was uh, highlight the important areas of the brain and psychiatric morbidity associated with it. This was the question. So one area is hippocampal, diencephalic, and parahippocampal retrosplenial network. Hippocampal, diencephalic, and parahippocampal retrosplenial area. आप इसको सीधे लफ्जों में हिपोकैम्पस एंड एसोसिएटेड एरियाज कर दें। दूसरा है टेम्पोरल लोब, एमिगडाला, ऑर्बिटोफ्रंटल नेटवर्क। सो ऑर्बिटोफ्रंटल कॉर्टेक्स, जो टेम्पोरल लोब का हिस्सा और फ्रंटल लोब का हिस्सा आपस में मिल रहे हैं, जो इसको ऑर्बिटोफ्रंटल कॉर्टेक्स या टेम्पोरल एमिगडाला रीजन बोलते हैं, वो सेकेंड एरिया है, important. And the third is medial default network, right? Medial default network is related to something which is approximately all on the dorsomedial side. So the hippocampus and related areas are related with memory, you all know, and spatial orientation. And problems in this area leads to amnesia, Korsakoff syndrome, mild cognitive impairment, Alzheimer's disease, and balance syndrome. अगर आपको दो भी याद रह जाएं कि hippocampal area is associated with memory, so amnesia and dementia, Alzheimer's dementia, that will be enough. Then temporal area, basically it is associated with behavioral inhibitions, memory of temporarily complex visual information, olfactory and gustatory visceral functions, multimodal sensory integration, object reward association and learning, and outcome monitoring. Now, these are complex terminologies, are difficult to understand, but temporal area or orbitofrontal cortex area is associated with one, memory, which is of complex task, and two, the sensory integration. These are two main associated things, and behavioral inhibition. So whenever you say behavioral disinhibition, when the behaviors are out of proportion than expected, that is coming from temporal area or orbitofrontal cortex. Like in OCD, when you keep on repeating, it is orbitofrontal cortex. This is behavioral inhibition goes away. Similarly, if you are having mania, you are very excited, you are shouting, screaming, so behavioral inhibition goes away. This is again temporoamygdala area. And associated phenomena with it are one, Alzheimer's disease, second, semantic dementia, third, Clover-Bushy syndrome. Now this syndrome was asked as a separate entity as well, Clover-Bushy syndrome. Bilateral ablation of the temporal lobes leads to hyperorality, hypersexuality, and hypersexuality, and disinhibited aggression, sheer aggression. And that is called Clover-Bushy syndrome. So a separate question with the Clover-Bushy syndrome means hypersexuality, hyperorality, ज़्यादा खाना है, and हर चीज को मुंह में उठा के डाल देना है, and of course aggression, severe intense reactions to any stimulus. This is called Clover-Bushy syndrome. Another separate SAQ is asked related to it. And of course, if there is a problem in this area, they can be leading to temporal lobe epilepsy. So तीन चीजें अगर आपको याद रहें तो bipolar disorders, Clover-Bushy syndrome, and temporal lobe epilepsy, that's enough. Third area, the dorsomedial default network, which is associated in approximately a bigger area of the brain, is related to pain perception, mentalizing, empathy, autobiographical memory, and person's perception. Anything I am perceiving comes through that. And expressive emotions are related to it. So, empathy, mentalizing, attention, perception is associated with this area. And of course, if there is a problem in it, you can have schizophrenia, depression, ADHD, anxiety disorders, autism, all of these areas are related to it. So, three basic areas: hippocampus and related areas, memory, Korsakoff syndrome, dementia, temporal amygdala area, basically temporal lobe epilepsy, Clover-Bushy syndrome, and bipolar affective disorder. Dorsomedial area, mentalizing, empathy, and perception, leading to depression, autism, schizophrenia, OCD, etc., etc. So these are all related.
सर
G.
सर मेंटलाइजिंग का मतलब क्या होता है?
मेंटलाइजिंग, अगर किसी चीज को आप परसीव करके, ठीक है, ये बहुत बड़ा कॉन्सेप्ट है लेकिन ब्रीफली थोड़ा सा बता दूं। मेंटलाइजिंग होता है कि हम मुख्तलिफ पैरामीटर्स को एसेस करते हुए उनके नटशेल में एक चीज प्रोड्यूस करते हैं। मसलन मैं कैसे उठता हूं, कैसे बैठता हूं, क्या सोच रहा हूं, कितना एंग्शियस हूं, कितना लोगों को देख रहा हूं, अगर मुझे उस सारी चीजों के फ्रेमवर्क में देख के मॉडिफाई किया जाए, इसको मेंटलाइजिंग बोलते हैं। एक टीवी सीरियल आता है मेंटलिस्ट के नाम से, आई डोंट नो आप लोगों ने देखा है कि नहीं देखा। मेंटलिस्ट इज अ वेरी सक्सेसफुल सीजन which ran for about 8 seasons or something, or maybe 6 seasons. I don't remember exactly. It was back in about 8, 10 years ago. Mentalizing is very much predicted in that. So उसमें वो जो mentalist है, he basically assess the people, their behaviors, and then he predicts that this is what is happening to you and this is what was the cause for it. This is mentalizing, right? So मेरे पीछे दिमाग में क्या चल रहा है और मैं कैसे उसको एक्सप्रेस कर रहा हूँ और किन वजूहात पे एक्सप्रेस कर रहा हूँ, दैट इज मेंटलाइजिंग। हो गया?
सर
हाँ।
ये जो अभी हम पिछली स्लाइड देख रहे थे इसमें जो ओसीडी की एग्जांपल थी, आई थिंक वो दो एरियाज पे ओवरलैप करती है, नहीं? वो ऑर्बिटो
इसीलिए
फ्रंटल कॉर्टेक्स भी इसमें
हाँ,
इन्वॉल्व होता है।
बिल्कुल करती है। कुछ डिसऑर्डर्स ऐसे हैं जो जनरली दिमाग के किसी एक स्पेसिफिक फोकस्ड एरिया से जनरेट नहीं हो रहे, जो बहुत सारे एरिया से इवॉल्व हो रहे हैं। उसमें ओसीडी एक खास प्रॉब्लम। ऑर्बिटोफ्रंटल कॉर्टेक्स is the main area, but again, generally, the rest of the areas are involved as well. Because OCD में thoughts are one thing, ruminations are one thing, but the compulsions are associated as well. And the compulsions are associated with mentalizing, empathy, monitoring, person's perception. So उसमें compulsions भी associated है. So motor component and so thought component both are associated with different areas. Got it? Okay.
यस।
आगे चलते हैं. There was a question, what are the branches of psychology? Right? There is pure psychology and there is applied psychology. And the branches of psychology are divided into psychology and applied psychology. When we say applied psychology, it covers clinical psychology, educational psychology, legal psychology, military psychology, political psychology, and criminal psychology. This is applied, so in various fields and domains. And then there is psychology, which is general psychology, abnormal psychology, social psychology, experimental psychology, parapsychology, and geopsychology. So psychology has multiple domains. Two main branches are pure psychology and applied psychology. Pure psychology includes general psychology, abnormal psychology, experimental psychology, physiological psychology, parapsychology, geopsychology. And applied psychology means educational psychology, clinical psychology, industrial, legal, military, political, and criminal. There are other domains as well. So this was the question and straight answer to it. Then, what are the NPI, non-pharmacological interventions in the treatment of, I think, depression? This was the question. So NPI, non-pharmacological interventions, whenever you say NPI of schizophrenia, NPI of depression, NPI of anxiety, means without medication, non-pharmacological interventions, and mostly means psychological intervention or social interventions or behavioral interventions. These are basically NPI. So whenever the word uses NPI, non-pharmacological intervention, you have to focus on sociology, psychology, and other aspects, not the medication. So whenever we say non-pharmacological interventions of depression, for example, so immediate is confidence building, removal of the stressors, normalization of behavior, differential reinforcement. Short-term goals are individual and family counseling, and long-term goal are specific individual or family therapy and social intervention. These are all NPIs, and these are generally the same for most of the disorders, but of course there are few specific things associated in between. Treatment, pharmacotherapy is a third line treatment. For example, as a third line treatment is called NPI as well. Antidepressants are typically indicated for treatment of comorbid anxiety and depressive disorders. So whenever you say NPI, you focus on social and psychological methodologies to treat the disorders, but these pharmacotherapy is considered as a low line treatment option, not the first and second line treatment option. Now, there was a question about the headaches, a very common question and asked multiple times. What are the different types of headaches and what treatment should be administered to it? One, cervicogenic headache. Two, migraine headaches. Three, cluster headaches. Four, hemicrania continua. And last, tension headaches. Now, all of these five types of headaches, you should remember: cervicogenic, migraine, cluster, hemicrania, tension. Five types of headaches. Most of these headaches are more common in females except for cluster headache, which is more common in males. So if a male is complaining of a headache, the first thing that will come to my mind will be cluster headache. The rest of the headaches are for the females. So cervicogenic female, common in females. Cluster headache, common in females. Migraine, common in females. Hemicrania, common in females. And tension headache, common in females. Usually cervicogenic headache is unilateral. Migraine is unilateral as well. Cluster headache is unilateral as well. And hemicrania is unilateral as well, except for tension headaches. So if a male presents to me with the complaints of the headache and it is bilateral, I will immediately say that this is basically tension headache. If a male presents to me with a unilateral headache, the first thing will come to my mind will be cluster headache. Now, location. Cervicogenic headache is usually in occipital and frontoparietal and orbital areas. सामने और पीछे हेडेक होती, यहाँ नहीं होती. Migraines are usually unilateral, आंखों में और पीछे की तरफ, साइडों पे, फेस के ऊपर, टेम्पोरल एरिया में माइग्रेन हेडेक्स. क्लस्टर हेडेक्स यूजुअली ऑर्बिटल एंड टेम्पोरल, साइडों पे ये फड़कती हैं चीजें. Hemicrania continua, frontal, temporal, orbital and hemicranial, and tension headache is frontal, occipital and circumferential. So जो पूरे सर में पकड़ है वो tension headache है. Migraine unilateral, Tension headache bilateral. The rest of the headaches are unilateral as well. Duration. Cervicogenic headache is intermittent, comes and goes. Migraine, when comes, it takes time to settle down. कई घंटे रहती है, ठीक है. अगर हेडेक आती और जाती है तो मैं सर्वाइकोजेनिक को कॉज करूंगा. अगर मुसलसल रहती है मैं मीग्रेन को कॉज फील करूंगा कि दिस इज अ डिफरेंशियल डायग्नोसिस. Cluster headaches usually last for shorter period of time than migraine headaches. So if somebody settles down for migraine, then it lasts for a couple of days. But the cluster headache usually subsides in few hours. Hemicrania continua is constant with attacks, and tension headache is days to weeks. मुसलसल पिछले एक हफ्ते से सर में दर्द है, ठीक है, I will definitely consider tension headache. Triggers, as the name suggests, cervicogenic, neck movement, headache intensifies. Migraine, usually multiple reasons, flashes of light, smell of food, change of temperature, so many other causes. Cluster headaches, usually in alcohol withdrawals. Hemicrania, no cause is identified, and tension headache, multiple, but again, multiple in tension headaches, usually stress related issues, some other forms of physical or environmental factors can play in tension headache. Associated symptoms. In cervicogenic headaches, usually if you stabilize the neck, the headache goes away. In migraine headache, if usually the person goes off to sleep without any disturbances around, the headache goes away. In cluster headache, usually rhinorrhea, ptosis, and other symptoms are common. Hemicrania continua, mostly autonomic symptoms, palpitation, restlessness, breathing difficulties, increased heart rate. Those are the associated symptoms. And tension headache, decreased appetite, photophobia, phonophobia, etc. Treatment of cervicogenic headache is the treatment for basically cervical problems. Best treatment is non-physical, non-pharmacological, but anticonvulsants can be used as a pain relieving agents or NSAIDs or TCAs. Migraine headaches may triptans or ergot alkaloids are the first line treatment. Cluster headaches may usually ergots and triptans are used. Hemicrania, excellent response to indomethacin. And tension headache, analgesics, muscle relaxants, antidepressants, and other kind of treatment are usually helpful. So this is one of the questions. It's a complex, lengthy question, but it's not necessary they will ask you all five. They may ask you what are the five different types of headaches. You have to name the five and what are the treatment given for each, and you can just mention. So for two of them, it's triptans and ergots. For two of them is analgesics, like the cervicogenic and hemicrania, and one of them is usually removal of the stressful situation, whatever it is, muscle relaxants and analgesics. Okay, grief. Lots of questions are asked about the grief. The question on the exam was, what are the differences between grief and depression? And what are the various phases of grief? Kubler-Ross gave 5 stages of grief. Kubler-Ross. And they are basically associated with death and grief reactions as well. 1, denial. I won't accept that this is happening. Second is anger, when I will show severe reactions. I will shout, scream, cry, etc. Anger. Bargain. And then I will just say, ऐसा नहीं हो सकता. This is not possible for me. Why happening to me? So you bargain. And then you feel depressed and sad in the 4th stage. And then acceptance. Okay, fine. Whatever happened was then done. And now I have to move forward. Denial, anger, bargaining, depression, and acceptance. 5 stages of grief. Now, what are the differences between depression and grief? Lots of overlap. So the first and the foremost thing is that you have to understand that usually grief is after a loss, and depression after a loss takes some time to build up. Immediately after the loss, you will develop grief. It may convert into depression, but it may stay as a grief and resolve as a grief. So, this is a thin line and a boundary. So, if somebody comes to me with the loss and development of the symptoms, I will first consider grief. If the grief won't resolve, then I will treat depression. Symptoms are almost similar. In grief, there is irritability, anger, as I told you in the phases of the grief. Acceptance is difficult. Seeing or hearing the same person, sleep disruptions, appetite disturbances, weight loss, intense malaise, fatigue, slowness, lethargy, etc. In depression, the most complicated symptoms are that we assess on mental state examination: worthlessness, helplessness, guilt feelings, hopelessness, and suicidal ideation. They are more common in depression. So, the mental state findings are more common in depression. Symptoms usually overlap. After the loss, grief is considered to be first, and the depression is considered afterwards. Then there was a question about the culture bound syndrome. Now, culture bound syndrome, every time in the exam, there is one question associated with it. What is culture bound syndrome? What are different types of culture bound syndrome? How will you define culture bound syndrome? Uh, and they may mention what is Kuru, what is Dhat syndrome. Dhat syndrome is not mentioned here, which is a Pakistani version of culture bound syndrome, Dhat syndrome. I will just come to it. So, culture bound syndrome, by definition, is collection of signs and symptoms which is restricted to a limited number of cultures, primarily by reasons of certain of their psychosocial features. So, if in a specific society, because of some cultural phenomena, like in Pakistan, it's a very clear concept that one drop of semen is equivalent to 1 liter of blood. And unfortunately, the traditional faith healers in Pakistan, they have highlighted this process that if you lose a drop of semen, it will cause lots and lots of weakness. It's a very culturally acceptable thing. The reason I'm explaining this in this sense is that it's easier to understand for you to understand. So, culture bound syndrome, usually again related to a specific culture, specific societies, and restricted to those societies. Dhat syndrome, 1 drop of semen equals to lots of waste of energy and 1 liter of blood. So, people who loses semen as nocturnal emission, usually the faith healer says that you are weak because you are losing your semen. Of course, it's not reality, right? You all know that the semen is collected in a sac, and when it overflows, it dribbles out, so you have nocturnal emission. And then you have wet dreams and all that stuff. So that's a different story. So actual is something else, but belief is something else. In culture bound syndrome, categorization as a disease in the culture, that is not a voluntary behavior or false claim. Widespread familiarity in the same culture. So everybody believes in the same. If everybody is not believing the same, it will be turned into a delusion, right? But because most of the people believe in it, so it's an overvalued idea, which is a culture bound syndrome. Complete lack of familiarity of the condition to the people in other cultures. People won't be able to understand the Dhat syndrome in Canada or America. But in Pakistan, if you say Dhat syndrome, most of the people, specifically related to the healthcare system, would be able to understand what they are talking about. No objectively demonstrable biochemical or tissue abnormalities. The condition is usually recognized and treated by the folk of medicine of the culture. So the traditional faith healers usually treats them. Various culture-bound syndromes. Dhat syndrome is not mentioned here, but Mubashir साहब की किताब में अल्लाह जन्नत नसीब करे उन्होंने धात syndrome को mention किया था और ज़्यादातर psychiatrists in Pakistan they do believe in it. AMOC, Malaysia. Arctic hysteria, as name elicits, Alaska. Atique de nervios, Latin America. Brain fag, West Africa. Coro, Malaysia. Mal de Ojo, Spain. Windigo, Native Americans. Even if you won't be able to correlate them, you just have to remember the names. AMOC, Coro, brain fag, Arctic hysteria, Windigo. 3-4 नाम लिख देंगे या धात syndrome. That's enough. AMOC is dissociative, hysterical reaction, extreme exterior hysterical reaction. Arctic hysteria is also hysterical reaction. Again, abrupt dissociative episodes. Brain fag, again, it is related to dissociative symptoms, difficulty in concentration and remembering. And Coro, sudden and extreme and intense anxiety that my penis is going inside my body and it will disappear. It has started shrinking. It is Coro. अगर आपको ये तीन भी याद रह जाएं, AMOC, Coro, and Dhat syndrome, that's enough. So mention the name, 5 of them: AMOC, Coro, Dhat syndrome, brain fag, and Arctic hysteria. 5 of them are enough. Mostly anxiety and dissociative and hysterical symptoms in most of them. I hope you'll be able to attempt the question. Culture free versus culture fair intelligence test. So most of the psychometric tests which are utilized in psychology or for psychometric assessments are developed in West. For example, WAIS, Bachelor Adult Intelligence Scale. Now, WAIS is developed in West and used to assess the memory of an individual, or IQ assessment के लिए हम WAIS इस्तेमाल करते हैं. Now, the problem was that it was basically in English, and when it was, and the people in Pakistan started using it, the psychologist or whosoever was administering the psychometric test, they had to translate few things into Urdu to administer it to people who are not able to understand English. Those type of situations causes problems. So the culture free versus culture fair test, intelligence test, are a problem. And again, as I told you, most of the tests of intelligence, which we talked about earlier as well, and some we will talk in later as well, WAIS, WISC, Luria, Nebraska, Bender Gestalt test, they're all in English. Their interpretations are in English. Their mostly language is in English. And when it is translated, they may create a bias, and the results may not be as expected. This is what the question was. Now, culture-free test, purpose is that they should be able to remove the biases of the language and the culture. So there are few things which are mentioned in the D's test which may not be acceptable in our culture. Like I gave you the example, wearing a mini skirt in West is fine, in Pakistan, again, considered deviation from normality. And to remove that bias, then it will be a culture-free test, and we have to go for it. You have to explain this from various examples. That culture-free test means usme various concepts are actually acceptable to people. The language is very simple and clear in the local language. They are able to express it, whatever is culturally acceptable and not culturally biased. Culture-free test means this. Explanation. So far, तर्ज़ तगाफुल है, सो वो इनको मुबारक, अर्ज़ तमन्ना है, सो हम करते रहेंगे. So मेरा काम है पढ़ाना, मैं पढ़ाता रहूँगा, आप लोग आएं या ना आएं. I'm sorry. Okay, next please. We will move forward with the next question. So there was a question, what are the methods of reinforcements? 4 different methodologies of reinforcement. One is fixed ratio, second is variable ratio, third is fixed interval, and fourth is variable intervals. So whenever we have to give the reinforcement to modify the behavior, there are four different kinds of methodologies. Fixed ratio, every 5 steps and you will get this. This is fixed ratio. Every seventh day you will get this. This is a fixed ratio. Variable ratio, sometimes I do this and I am given this much reward, and sometimes I do this and I am given this much reward. That is variable ratio. So I don't know what will be given to me in reward to my behaviors, whatever is the reinforcer. So it is variable ratio. Fixed interval, fifth of every month I get the salary. This is the fixed interval reinforcer. Variable interval, I get bonuses sometimes, maybe once or in a year or twice in a year, sometimes in month of March, sometimes in month of September. That is variable interval schedule. So when they ask about the what are the four different types of the in reinforcement schedules, you say fixed ratio, variable ratio, fixed interval, variable interval. Usually, continuous reinforcers are used in organizations, bigger organizations, as a part of the salary. You work for every month, and by the end of the month, you get a salary for what you have done. Fixed interval, usually weekly, bi-monthly, monthly paychecks. Variable intervals, transfer unexpected bonuses. Fixed ratio, piece rate commission on units sold. Variable ratio, random checks for quality, yield praise for doing good work. Right? So these are the four schedules. Yeah.
ये जो अभी आप ये जो लास्ट स्लाइड थी इसमें स्पेसिफिकली जो बात हो रही है वो पॉजिटिव रीइंफोर्समेंट की थी.
Oh,
Are
definitely.
the intervals for positive reinforcement?
Oh, yes, definitely. Definitely. They are all positive reinforcers. उसकी बात हो रही. So positive reinforcement and schedules, four different types. Yes, you can add positive into it. Right?
Yes, sir. Yes, sir. Okay. Thank you.
Okay. Confidentiality पे मैंने लास्ट टाइम भी एक स्लाइड की थी, फर्दर उसको बिल्डअप करूंगा. Limits of confidentiality. So there are, what are the actually problems associated with confidentiality? So limits of the confidentiality are the problems in actually tertiary care centers, in medical schools, in wards where students, postgraduate residents, and the consultants are working in harmony. In wherever situation where a multidisciplinary team is acting to provide the coverage. So there is not one doctor involved. There are multiple people involved in the patient care. And then there are limits to the confidentiality. So I dictate the notes in the dictaphone. Those notes goes to the third party. They type them, it comes back, I check them, authenticate them, and it's printed and put in the patient files. So there is a third person involved in confidentiality, and that person actually, the clerk who is typing the notes, knows everything about the patient. So this is unfortunately the limit of confidentiality. Then if I have a difficult patient and I go and ask somebody, like the resident goes to somebody, to the consultant, that I have seen this patient is doing this, and my diagnosis is this, what is your diagnosis? So now another person is involved into it. This is again limit of confidentiality, because patient never met that consultant face to face. It is dependent on the intermediate person to convey the information. So the information is conveyed to the person, but there is a limit. I haven't asked the patient directly, or the consultant hasn't seen the patient directly. That's the limit of confidentiality. Then when again resident is supervised by some consultant, when client has given the consent, We ask the interview in the exam situation, मैं आपसे कुछ बातें कर रहा हूँ जो सही है रास में रखी जाएंगी और आपकी इजाजत बगैर किसी और को नहीं बताई जाएंगी, और वो कहता है yes. But there are people around in the examination center as well, besides the examiner. So there are ward boys, there are tea person, there is a scoring person, there is a bell person. All of those people are listening to whatever the patient is saying. Although patient has given the consent to you, but what about the consent for the rest of the people? So this is the limit of the confidentiality. Then when a client poses dangers to self or others, if he expresses a suicidal ideation, I can breach the confidentiality. But that is a limit, right? Where I will assess that this person is dangerous to others. It's my assessment. It may be wrong. It may be correct as well. I just was watching Dr. Shaheen Hari's a teaser that there was a person seen in her clinic who was a murderer. I have seen a person, number of people who have done that. But again, mentioning about their stories, and if that story is somewhere else as well, people can correlate, and the breach of confidentiality could be a problem. When a counselor suspects abuse or neglect of a child or vulnerable adult, so if I believe that this mother is having postpartum psychosis and there are possibilities of infanticide, I can breach the confidentiality for mothers and infants' sake. But again, there is a limit to confidentiality. And अगेन द कोर्ट ऑर्डर्स मी सारी फाइलें लेकर आप कोर्ट में हाजिर हो जाएं और पेशेंट के बारे में बयान दें. सो आई हैव टू शो देम ऑल द records for the legal purposes. There is a breach of confidentiality, and this is the limitation of confidentiality. When does a therapist have to break the confidentiality? One, when the patient tells me that you can give this information to anybody you like. Two, when I am asking for other services to provide help, like social services, like medical people, like surgical people, or anybody else, then there is a possibility that you can breach the confidentiality if the patient's life is endangered. The client is a danger to oneself or others, and there is a suspicion of child abuse, you can breach the confidentiality. Okay, come on, move forward now. Where is it? Okay, no, okay, let's move forward. Okay, then there was a question, what is agoraphobia and systemic desensitization? Lots of questions are asked about systemic desensitization. So let's talk about agoraphobia first. So anything which leads to a fear in the mind that something will happen to me if I will do this, like leaving the home. If I'll go in a crowded place, I will stop breathing. Crowds and lines, enclosed spaces, lift and closed spaces, open spaces, out in the public, out in the market, out in the shopping mall, something will happen to me and I won't be able to escape or find a refuge. This is agoraphobia, typical definition. Now, what do you do for systemic desensitization? I will cover this topic again as well. I hope I have another slide about SD, but systemic desensitization, but still, 5 R's. 1, react. Okay, fine. You have this problem. Let's see what are the parameters associated with. Retreat. First, you have to withdraw, then relax, then recover, and then repeat, go back again. So if I am fearful of closed spaces, first reaction is so you have to just pull yourself back, you have to relax, then you have to recover and try it again. These are 5 R's in systemic desensitization. Second important parameter is that you go from a lower level to upper level. So the least fearful to the most fearful thing. So 1, you escalate from least to most, and then you have to do 5 R's: react, retreat, relax, recover, repeat. These are actually practice systematic desensitization module. Exposure and response prevention, very commonly used in OCD. Exposure and response prevention, it is part of the behavior therapy plan. And again, least feared to most feared situation. Least feared, like if he is fearful, a person that's suffering from OCD is fearful of touching the garbage, then you will, uh, again, first of all, cleaning your own self, cleaning your own urine, cleaning your own feces. That is the first step. Then touching the waste bin, then touching objects with friend's house, eating at friend's house, going to toilets with the friend's house, touching doors and objects outside the home, going to eat outside the home, and going to the toilet in public toilets. So least fear to most fear, you make a hierarchy, and do you gradually expose the person, reduces the anxiety, relax them down, and expose them again. And then every time you do it, gradually it is again systemic desensitization and exposure and response prevention. The responses are less and less fear, so you start feeling better. Goal is experimentally test the accuracy of anxious predictions such as disastrous consequences, intrusive thoughts, anxiety is unbearable, uncertainty is intolerable. Practice confronting obsessional thoughts, reduce the use of safety barriers, response prevention. Emphasis on just experiencing anxiety and obsessive thoughts, and anxiety is usually gradually reduced to from 100 to 80, 80 to 70, 70 to 20, and then it goes away. Psychiatrists identify a list of target symptoms using YBOC, list of items ranked by patient from least to the most, 13 to 20 weekly sessions, sometimes monthly booster sessions set up to prevent relapse. This is the exposure and response prevention therapy, briefly to attempt in the exam question. Then, okay, there was an Prochaska and De Clementi motivational interviewing. And that motivational interviewing is having certain phases and interventional strategies in possible situation of substance abuse, addiction, even they can be used for other behavior modifications as well. Prochaska and De Clementi gave stages like pre-contemplation, then contemplation, preparation, action, maintenance, and relapse. This is motivational interviewing or trans-theoretical model of change in behavior. It is also called trans-theoretical model of change of behavior. So any change in the behavior can be done by assessing the pre-contemplation, contemplation, preparation, action, maintenance, and relapse. How do we do that? It's called the stepped care model. First, you screen, then you refer, third, you self-help, then in-person help, then individual theory, and then intensive individual therapy, and then long-term therapies. These are various escalating, complicated theoretical stuff. So if the question is, how do we change the behavior in substance abuse? You will say Prochaska and De Clementi gave these 5 models. You go for a step-up situation, you screen, you evaluate, you intervene, first the self-help, then in-person, then group individual therapy, then intensive individual therapy, and then group therapy can be utilized. Okay. Oh, healthcare expenditure. What was the question here? Health outcomes and culture, probably. I don't remember the question for this. Economic stability, employment, income system. Sorry, I forgot the questions related to it. I just answered. मैंने पहले भी सोचा था मैं question साथ add कर दूं. Anyways, so the question is missing, but I will maybe, if I remember, I'll cover it up. This is pathways to care. Okay. There are various situations in healthcare system So when the patient comes to you, by the time he reaches a psychiatrist, he has already consulted number of people in between. Usually, in low middle income countries and developed countries, the pathways to care are different. In high income countries, the pathways to care is that if the patient feels any problems, either he goes to emergency or he consults the family doctor and the family doctors refers them to the specialist. This is the pathway to care. And then similarly, the healthcare professional in the specialized services sends the notes to the family doctors, and family doctors are able to understand what is the diagnosis, what the treatment plan, and they follow it up, and that there is a stability. So the question in exam was, what are the pathways to care in healthcare system in a low middle income country? Complicated question. So there are multiple things involved in it. One, पैसा कहाँ से आएगा, इलाज कौन करवाएगा, कहाँ पे इलाज होगा, कैसे इलाज होगा, होम्योपैथी का इलाज होगा कि एलोपैथी का इलाज होगा कि हिकमत का इलाज होगा, उस इलाज से कैसी चीज़ें ठीक होंगी, कितनी देर का इलाज होगा, कितना अर्सा दवाई खानी पड़ेगी, दवाई के पैसे कौन देगा, काम पे गए तो क्या होगा, काम पे ना गए तो क्या होगा, तनख्वाह बंद हो गई तो क्या होगा, बीवी बच्चे कौन संभालेगा. These are all associated areas in pathways to care. And this complex slide is actually explaining that. But what I have told you, that's enough to write down in an exam situation. So remember, the pathways to care in developed country, there is insurance system, there is social system where government provides help, financial, physical, other helps. There are multidisciplinary teams, there are specialized care and the general health care. But in low middle income countries, all of these things probably comes from the person's own pocket and the family has to bear the expenses of everything. बच्चों का खाना, बीवी को संभालना, नौकरी की छुट्टी लेना, नौकरी से तनख्वाह ना मिलना, उस सूरत में क्या होना. These are all pathways to care. And all of these economic and financial and healthcare system engaged together involves in the pathways to care. Question attempt हो जाएगा, inshallah. Okay, what are the exam में 5 people important in mental health team. There was another question in exam that you are a psychiatrist appointment in a rural setting of Punjab and you have to establish a mental health team and a 20-bedded unit in that district. How will you proceed? So whenever you say mental health team, which is in usually even in the tertiary care centers in Pakistan, in mental health team there are only 2 people, psychologist and psychiatrist. But actually it is not like that, right? There are more things in mental health team. One, dietitian. So you prescribe a drug, they gain the weight, and you have to make sure that they control their weight. So dietitian is a mental health team person. Psychiatric social worker. So he will be having some problems associated with his mental illnesses as far as his home is concerned, family is concerned, work is concerned, and other areas associated with it, financial, economical, social. So you need a social worker. Psychiatric nurse. So if the person is admitted into the inpatient unit, he will definitely need a specialized nurse to control the behaviors without the medication or with the medication. So you need a psychiatric nurse. Psychiatrist, of course, to treat the person overall, making the healthcare plan and delivering it. Clinical psychologist, assessing and intervening according to the psychological need of a person. Occupational therapist. So there may be some areas where he needs some interventions related to the sensory system or other system where he may need occupational therapist. Pharmacist who will dispense the medication, make sure that the person is able to understand the pros and cons of taking the medication, the regularity in the medication, route of administration, etc., etc. And counselor. So, in an ideal mental health team, you have a counselor, dietitian, psychiatric social worker, psychiatric nurse, psychiatrist, clinical psychologist, occupational therapist, pharmacist, and a counselor. All of them. And this is what is needed in exam to respond back. Conflict. What is conflict resolution and what is a conflict? Okay, I have few more minutes. Okay. According to Follett, conflict is the appearance of difference and difference of opinions of interest. Antecedent conditions, for example, scarcity of resources, policy differences among individuals, etc. Affective states of the individuals involved, for example, stress, tension, hostility, anxiety. Cognitive states of individuals, that is, their perception of awareness of conflict situation, and changing behavior ranging from passive resistance to overt aggression. So the question was, what is the definition of a conflict? In layman term, conflict is again when you have differences of opinion with the other person. But when you are working in a setting where there is a hierarchy of management, so even in a tertiary care center, you have again house officers, then residents, medical officers, SR, AP, associate, and professor. This hierarchy, so you may disagree with one of your associate professors because he was nasty or bad to you, and then you develop some resistance to it. So these are the parameters. One, you may disagree about his policies, you may show hostility, you may have a perception of awareness that this person is not appropriate, I should not see him again in the ward, and this behavior may change you to have a passive resistance, or maybe you will just slap him one day. This is the definition of a conflict. Now, the next question was, how will you resolve it? Let's hope I have done that. Oh, it's not here. So maybe in some other slide. We'll come back to you. I'm sorry, it's very haphazard because the questions keep on popping up and I kept on attempting them, but I was not able to put them in the sequence. Sorry about that. Okay, so this is conflict resolution. Okay, so importance of achieving the goal. When you have a conflict, understanding the problem, assessing the situation, one on one conversation, establishing a common goal, and devising the solution are the steps for conflict resolution. Understanding the problem. I will understand that I have a problems with the associate professor, but he is senior and he is in power. Assessing the situation. If I'll go beyond certain means, I may lose some few things, may lose my residency, maybe the professor will be angry with me, maybe something will happen. One-on-one conversation. So I will try to talk to the person, masla ki ye ਤੁਹਾਨੂੰ ਕੀ ਚਾਹੀਦਾ? Again, not like this, of course, but in one-on-one conversation, discussing, evaluating, and coming to a point where things can be addressed. And then establishing a common goal. Okay, fine. You have a problem for me. I will try to address the problem and overcome the problems, and then let's see what happens. And you have to give me the margin of that thing as well, and help me in overcoming the situation. This is the best way to go for it, honestly speaking. And devising the solutions. Okay, what should we do to make sure that I should not have problems with you and you should not have problems with me, and things can be sorted out. This is conflict resolution. So competing, collaborating, compromising, avoiding, and accommodating are the 5 parameters of conflict resolution. Moving ahead. Stressors. So there was a question that there is stress and there is eustress. How will you define eustress versus distress? So whenever we are feeling stressful, like आप लोगों का एग्जाम होना है, अभी पता नहीं है SAQs हैं कि MCQs हैं, आप stressful feel कर रहे हैं. So जब भी आपको stress आता है, आपकी performance enhance हो जाती है. This is eustress. When you feel stressed up, your performance increases, you work harder, you sit for more hours in front of the book, you read more, you study more, So this is you stress. When your stress goes up, your performance goes up too. This is you stress. But there is a point when your stress keeps on going up and your performance starts reducing. Uh, so your stress is going up, but your performance starts coming down. That is distress. Common definition. This curve was specifically named. I don't remember the name at the moment, but if I'll remember it, I'll let you know. This type of, again, whenever you have certain targets or the goals to achieve, you feel stressed up, you work on it, and you achieve the goals. This is you stress. But when the stress is too much, your performance starts going down, and then your performance comes to zero at certain point in time. The point at which your performance is deteriorating because of the stress, it is distress. Eustress or
Sir, this
positive
curve
stress.
is Yerkes-Dodson curve, if I'm pronouncing it
Yerkes
right.
Dodson curve. Exactly. Absolutely. Yerkes Dodson curve. Yerkes. Yerkes Dioda. Very good. Shabash. Eustress or positive stress has the following characteristics. It motivates you, focuses you, it increases your short term memory, it makes you feel excited, it improves the performance, you our coping abilities are enhanced, and you build resilience. But the distress, when it goes beyond that and it starts affecting your health, it causes anxiety or concern, can be short or long term, is perceived as outside of our coping abilities, feels unpresent, decreases the performance, can lead to mental and physical problems. So eustress and distress, the definition. यर्कीज डॉटसन कर्व। परवीन शाकिर का एक शेर है, जहां सवाल के बदले सवाल होता है वहां से मोहब्बतों का जवाल होता है। किसी को अपना बनाना हुनर ही सही, किसी का बन के रहना कमाल होता है। Try to be for somebody. Difference between Freud and Jung. This was another question. What is the difference between the psychoanalytical, psychodynamic theories given by Freud and Jung? There were actually 4 questions related to the same topic, and all of them are the same themes. Most of Jung's assumptions of his analytical psychology reflect his theoretical differences with the Freud. फ्रॉइड ने वी हैव कवर्ड इट इड ईगो एंड सुपर ईगो का कॉन्सेप्ट here. Jungian therapy is less concerned with the repressed childhood experiences. We are shaped by our future aspirations too. The libido is not just a sexual energy, but instead a generalized psychic energy. The purpose of psychic energy is to motivate the individual in a number of important ways, including spirituality, intellectuality, and creativity. So, has given the theory of id, ego, and superego, and he feels that all the defense mechanisms are playing the part, and your the sexual drives are actually linked to your future. But Jung said, no, it's not the childhood experiences, it's not the other areas, it's actually the future. We have to think about it, we have to drive the energy for it, and we have to work on it. And working on it involves spirituality, intellectuality, and creativity. And Jung generalized source of psychic energy is motivation. For Freud, the psychic source of energy was sexual gratification, वो Oedipus complex or Electra complex से related. Jung, a storehouse of repressed memories specific to the individual and our ancestral past. And Freud, a storehouse for unacceptable repressed desires specific to individuals. For Jung, past experiences in addition to future aspirations are important. And for Freud, only the past experiences are important. So the question attempted. Now there was another question. What is CBT? Indications: depression, anxiety, panic, phobia, anticipatory anxiety, problem solving methods. Now there is a CBT for psychosis as well. So depression, anxiety, panic, phobias, anticipatory anxiety, teaching, problem solving, and CBT for psychosis. These are indications for CBT exam question. And core components and characteristics of the CBT: 160 to 90-minute session per week, typically 8 to 12 weeks. Symptoms measures are collected frequently. Treatment goal oriented and collaborative. Patient is expected to be active participant. Treatment is focused on changing current problematic or maladaptive thoughts or behaviors, and weekly homework assignments are given in CBT. Okay, just again, I think I am going. Okay, I still have few slides left, but unfortunately, again, it's been too much of a time, so I will stop here. Any question, anything related so far? Anybody? No? I know, I
Uh,
understand. Yeah, today is the